So let's go to the cath lab.
Hello.
Hello, Robert, Jose,
Yes.
Yuda.
Yes,
It's glad to
we're,
see you on a big screen. You just joined us in the right moment, and I'm happy to see you smiling there.
Yes, yeah. I think Yura had some inside information here. He came up here for a little bit. We had a little bit of excitement here, but I think things are under control, and I just want to introduce you to the staff here. We have Janine, and we have Anne, the two nurses here. We have Jesus, our technician. We have Judah, who is our second interventional fellow here. We also have help from the Abiomed. We have Maggie. We have Maggie here. So Judah is going to...
We have Danny.
Yeah, and Danny is here as well, a third nurse, and Denise is outside. She is manning the hemodynamics.
Just before you start, Robert, can I ask the panel members to join Ajay, please? Jason? Mark, can you join us as well?
Great.
Okay, Robert, Jose, please
right.
present your case.
So Judah is going to go
Michael?
through the case.
Can you join us?
So good afternoon, everybody. So the patient we have today on our table is a 66-year-old gentleman. He's a long-standing diabetic. He's also a former smoker. He initially came to the hospital with 2 episodes of near syncope, and telemetry was demonstrated several episodes of non-sustained VT. Incidentally, a head CT demonstrated multiple small infarcts thought to be embolic in nature, and so he was started on systemic anticoagulation with a NOAC. You see his other medical history there. His EKG was sinus rhythm with an isolated Q wave in V3 and diffuse ST depressions, particularly infralaterally. His echo showed a mild LV dilatation, severe diffuse left ventricular hypokinesis with an estimated EF of 20% and a relatively preserved RV function without significant valve disease. His coronary angiogram demonstrated a left main equivalent. By that we mean severe ostial and proximal circ stenosis as well as severe proximal and mid-LAD disease. He was seen by our cardiothoracic colleagues and deemed to be at high risk for surgical revascularization, and the decision was made for a protected PCI approach using an Impella CP with plans for bifurcation stenting of his circ and LAD.
Yes, thank you, Judah. So because the lesion involved the proximal circ as well as probably extensioning to the left main, what we decided to do was start out the case with a IVUS, and just by having the IVUS in the left anterior descending artery, which was very calcified, I think it's notable. I think it's worthwhile mentioning that the IVUS sort of stopped in the mid-LAD. The lesion was so tight that we could not advance the IVUS beyond the mid-LAD. We'll show you the angiogram very soon. And while this was, at this point, we did not have the Impella in. Just by the IVUS restricting blood flow, the patient decompensated, and we had to urgently put in an Impella, which stabilized the situation. Can we show the hemodynamics on the screen, please? It's already on. So what we see here is that you have a heart rate in the 120s, but then if you look at the pressure tracing, that you have basically pulsus alternans, I guess severe pulsus alternans, or something of that nature, because you can see that not all of the QRS complexes electrically is being transmitted into a mechanical pulse. So that shows you just how unstable this patient is, and I think that without the Impella in right now, we would have been in a dire situation. Let me show you the angiograms here.
Important to note is that probably 5 minutes ago we had no pulsatility for about 5 minutes while we were trying to stabilize him.
What's that? Kira, go ahead.
No, I was just saying, he's in rapid AFib right now, or you had to give him a bunch of epi or something? Or?
Yeah, we had to give him epinephrine, and we tried to break it. Unfortunately, we were not successful. So these are the.
Do you want to show us the angiogram?
So here's the angiogram. So this is not only a left main equivalent. What we have is it's also a left dominant system. You can see that there is a very calcified proximal LAD lesion, a calcified, less calcified, but still calcified nevertheless, circ lesion, which is this angiographic stenosis is in the order of 90-95% at least. We did an IVUS of the LAD into the left main when the patient became unstable. Can we show the IVUS now, please? The IVUS run. All right. Here.
Can you click?
Can you see in the audience the IVUS?
Yes, we see it.
Here, hang on a second. Let me. So this is the IVUS run. This is, from about the mid LAD going into the left main.
So we see here the tight stenosis, just really lesion hugging the IVUS catheter.
Yeah, I mean, this is with a, even with a lower profile IVUS catheter, the problem is that, with this decompensated, ventricle, just putting a catheter across the left main likely obstructed flow into the dominant circ and potentially the LAD as well. And, with the sequela. Did you do a right heart cath to start off with? I mean, is his numbers pretty off to start off with?
Well, he didn't have a right heart cath on this admission. He did have a right heart cath when he initially presented, and that was when he was, fairly compensated. And if I remember correctly, actually his filling pressures weren't all that high. I can't attest that these are exactly the numbers, but his capillary wedge pressures were, I think, in the order of 15 to 17, and his cardiac index was about 1.9.
And the EDP today was up. I mean, before you put the Impella in.
Yeah, when the EDP, actually the EDP wasn't that elevated. I think the EDP was probably like 15 or 17 when we were putting in the Impella. The problem is, I think, as he started decompensating, we gave him epinephrine, and probably with the increased heart rate, he became overall globally ischemic, and then this it sort of becomes a tailspin. And I think, again, the only thing that sort of saved the patient is having the Impella ready and putting the Impella in urgently. So the initial plan for this is because of the calcification, we were planning to do a rotational atherectomy, but then, after the events that I described, we decided to change our strategy. We thought that, much of the decompensation was due to ischemia, and probably that 95% very osteal circ, which supplies a very, very large territory of a dominant circ. We decided to balloon that, and actually with ballooning that lesion, things became a little bit more stable. So we decided to abandon this idea of doing rotational atherectomy. So we're going to do just the PTCA of the left circ, the mid LAD, proximal LAD, and see where we can go from there. From the IVUS, it seems like the plaque in the proximal LAD extends into the left main. So the question here is, what sort of bifurcation stent strategy, if any, needs to be done here. So can we show the hemodynamic tracing again? It seems like the patient is now stabilized. Now it looks like he's out of the AFib or SVT that he was in. His heart rate is 89, as you can see, and he has good pulsatility. What are we flowing, Maggie?
Our average flow is 3.5 on the Impella, and our mean arterial is 82.
Yeah, so it really tells you, I mean, this is a patient that really needs Impella support. What we have is an Impella CP that we inserted through a 14 French left femoral artery access, and maximum flow rates for Impella CP you expect is like 3.5 to a 4, and we're flowing at very high rates on the impella.
Robert, can you show us again the coronary angiogram, the left main equivalent lesion, and let's maybe hear the panel members. How do you think that's the right strategy? How to really to treat, the ostial LAD, very tight ostial circ that is a left dominant. Jason, how would you do that? What would be your strategy?
Yeah, sure. It's a great question. And look, my preferred strategy in patients that are really unstable like this is to keep it absolutely as simple as possible. And it may not be the perfect longer-term solution, but SKS stenting is really simple. You don't have to recross. It's a couple of quick inflations and you're out. And I'd probably seriously consider just doing SKS. So with that's actually putting two wire both, pre-dilate both, put in two stents side by side, one the LAD, one the circ, blow them up simultaneously, maybe post-dilate and get out. And that avoids any need to recross or issues like that, which in an unstable patient like this I think is good to avoid. I'm sure there'll be other approaches.
We have Mark Menegus here that was busy all morning taking care of patient and luckily could join us now. So Mark, what do you think? How would you approach this patient?
I agree with Jason. I've done this in this kind of patient before, and I've done the same technique, SKS stenting. It's quick. It gets you out quickly, least amount of time, with depressed hemodynamics. I was even wondering if that circ was a CTO because the angulation is so severe. I wondered if that was a neolumen, but it looks like he got through it easily. So I think that was
so Ajay, our teacher called it a double barrel stent. So what would you do?
Yeah, I mean, for the unstable patient, it's the one technique that quickly restores flow and stabilizes things without worrying about dissections and otherwise. So I think once this has happened in this way, then it's always one of those things that you need to know how to be able to do. It's actually one of the reasons why, despite the fact that I'm a radial guy, for left main I'll still usually use a 6/7 slender and be able to have a 7 French in there just in case something happens with a side branch. Because this is educational, though, the point I would make is just that, given how severe the disease was in the ostium circ, these issues with the IVUS are anticipatable to some extent, and it was pretty clear that this was going to have to use support, and so in general, support before you even wire would probably be advisable. The other thing too is that with the support device, it acts like a VAD, and it may sound much to do a right heart cath, especially because it already has a pacer in. But when the patient starts dropping their pressure later in the case, you don't know if it's underfilling, you don't know if you need to actually give fluid boluses or otherwise. And so our practice typically is whenever we do these cases, we have the right heart cath in, and we monitor the pressures real time during the case, so we know exactly how to manage the fluids and or pressors during the case.
Michael?
Yeah, those are.
Well, I agree with the rest of the panel, but I think that, with the amount of calcification that you saw on that IVUS, it's going to be very difficult to get really good stent apposition using that technique. But I think at this point, we're in a bailout mode. Yeah.
So,
Good news is that those balloons did appear to expand.
correct. So we're going to do an.
But yeah, you don't want to have long amounts of underexpanded stent because they'll get you out of this case, but bad things can happen after.
Was this a high pressure balloon? How high did you go?
So we had a 2520 high pressure balloon that we went up to 18. Watch the wires. We went up to 20. We went up to at least 20 atmospheres.
Let's take a picture.
Okay.
So we're going to take a picture to see how this looks.
It works when you
So I just want to tell you that during the balloon inflation, again, we completely lost pulsatility.
The technique that he's using with disengaging the guide in between the injections is actually important in these types of cases, even with support, just to allow the patient to breathe and allow there to be perfusion of the vessels.
So one thing that that I going to ask the panel, I think that I'd like to do is that so we were not able to do what we needed to do, which was atherectomy, and so now we're thinking about second line procedures to take care of calcium. And I was wondering, we have a 2.5 angioscore ready, and we were thinking about using that to balloon both the left circumflex as well as the LAD. Any thoughts on using the angioscore at this point?
I mean, it's a good device. It's sort of semi-ish compliant with the nitinol wire, so that'll restrain it a little bit. With the issues that Mike raised about the expansion, though, you might want to, go even like a 3.0 or even bigger, potentially, just to be sure. Sure, you can dissect, but at least that way you'll be sure that the stents will expand.
Sure.
Yeah, especially in the left main that we saw the 360 degrees of calcium. I would go there with a 3.5 short. Those balloons are short, 6 and 10 millimeters. We can really go just the left main area and also LED.
So the good news is that it seems like this is a 2.5/15 angioscore that it went in pretty easily. Go up.
4, 6, 8,
10, 12, 14, 16.
14, 16.
It's a good test for the durability of the stents. If the angioscore balloon goes in, then a stent will go in for sure.
All right, so what we're going to do now is we're going to use the angioscore on the LED.
Going to use the same one or take a bigger one?
We could do I was planning on using the 2.5 angioscore, probably on the sort of the mid-distal LED, and then we're going to use a 3.0 probably for the proximal portion of the LED as well as the left main.
It's just not the 3.0, right? Yeah, but 3.0?
No, this is the 2.5.
2.5.
Yeah. All right, so we need the 3.
Fine, it'll open up.
There's not that much plaque in the left main per se. It's just that the ostium of the LED going into the left main that has a lot of plaque. Because I think that if the left main had a lot of plaque, and I agree that even a 3.0 is probably going to be a little bit undersized. So here.
We need a new one. Oh, it's good.
Okay, let's go up here.
Here you have some resistance.
Yes.
10, 12.
Down.
Sometimes the used angioscope balloons are getting very bulky and difficult to deliver.
Just got a new one, Robert.
So at this point, what we could do is we could take a newer angioscope, or we could just go in with a 3.0 non-compliant balloon, a 3.0 non-compliant balloon, like a 3.0 quantum, and use that. I think that's what I'm going to do. Can I get a 3.020 quantum, please? So our hemodynamics are much improved here with just the dilation of the LAD and the circ.
Can we see it?
Yeah. Can we put the hemodynamics?
We see it now.
Mean is what, 90?
So, Ajay, that's an excellent point. This is one of these patients where the EF on echo was 50 to 20%. The right heart cath rather on the initial presentation wasn't that bad, and I think we underestimated just how tenuous this patient was. And your point about putting a patient on ventricular support, some sort of a ventricular support even before you do the IVUS is a very good one.
I think the combination here of the left ventricular support and the better flow to the LAD and the sinus rhythm really works well for this patient.
Yes.
I mean, but the good thing is that, you had the support, you know what to do, you quickly wired, you ballooned, and, you stabilized. It's some people like to say that the device alone, solves all the problems, but if you're not experienced at knowing all those other techniques, disengaging the guy, doing all that other stuff, the support device is only going to get you so far. So clearly the experience showed as well.
12. 14, 16.
So this balloon went very well down to the LED. This is a 3.0 balloon?
Yes.
Non-compliant.
What's that leader row? Okay, go up here.
The patient is on Angiomax.
Yes, the patient's on Angiomax. We have an ACT that was about 400.
Okay.
So, RJ, what are your thoughts about the use of Angiomax versus heparin in patients who are undergoing atherectomy?
You know, I mean, I think we tend to use heparin, but it's not so much for the reversal issue. It's, I mean, basically, I think the cyanide data shows you can use Angiomax pretty effectively with atherectomy, and there's not much of an issue. We just have kind of gone more heparin as a whole. The one thing I will caution, though, against is that if you have a large column of stasis of blood for a CTO, or you're shoving the guide in and you're going to have support issues, the Angiomax issue can be real because it goes away pretty quickly and you can get in situ thrombosis. So for those types of cases where you're anticipating shoving the guide in and lots of exchanges and guideliners, I think it's probably prudent to avoid it.
I think there's a, now I'm going to put the balloon in a little bit because it seems like there's an area that hasn't quite expanded towards the distal end of the balloon, and I believe that was the area that the angioscore was getting stuck. So, all right, let's go.
How high do you go there?
We're going up to 18 atmospheres. We're going to go up to 20, yeah, there's that.
20.
Yeah.
Okay, it looks like dilating very well.
And again, can we go to the hemodynamics? You can see here during the balloon inflation that there's complete loss of pulsatility. Again, this is a intervention that just simply cannot be done without ventricular support. All right, let's go up here.
You see how important this LED is.
1820.
Down. All right.
You know, Robert, I was just going to ask you if you wanted to rethink your strategy in the left main bifurcation, but with this pressure tracing, I'm not sure I should ask that.
I think it's going to be the simplest strategy here. You know, I think the SKS is sounding, you know, more and more attractive to me.
Yeah, I agree.
We used to call that giving the coronary a drink.
It's nice to see the pulse coming back.
It is.
It's a good thing we don't have to deliver ciphers anymore.
Oh yes, absolutely. Okay, so I'm going to do an angiogram here.
You missed them.
We have to position the wire a little better in the LED, of course, but I think it looks well dilated. Dissection as we predicted, given the pressures that we went up on, but I mean, I think that comes par for the course, you know, when you're doing this. So now, I think that the LED, the longest stents that we have, and in fact what's available, I think are 38 stents. I don't know, maybe we should take a training shot. I have a feeling that we're going to end up with 2 stents in the LED. I don't think just one stent's going to be long enough.
Yeah, you might as well take the long one. And I don't know. Do you like the wiggle wire? We typically in this scenario would try to get a supportive wire down that LED and you know, at least help you. It may go, but.
Right. Yeah, I have. We have a 7 French sheath. I have 2 wires, and so I think certainly I think this will accommodate a 3rd wire. But well, and I'm going to think I'm going to think a little positively here and just ask for a 2.538 synergy.
Rob, your distal LAD wire is in a small septal there if you want to.
Right. Here. Good point, Jason. Okay. Yep.
Is he on any pressor, any inotrope or anything right now, or no?
He's on vasopressin. He's on a 5/10 of vasopressin right now. So you know, one thing that's I find very good, an advantage of these synergy stents and designs is as well, because in the past with the Sapphire stents, thick strutted, and you really had to think about, do I want to put in a 2.5 versus a 3.0? But now with some of these you know, newer generation stents, the synergy included, it seems like now you know, you have a 2.5 that can be expanded all the way up to a 4.0.
Let's give it 2 more Versed, please.
You have Versed drawn up over there. Let's give that.
All right. Well, let's give him 5 milligrams of Versed, please.
We're giving it.
Versed.
Let's give him 5
Wait a
milligrams.
second until he...
Yeah.
You gave the Versed?
Yeah, you gave the Versed?
Yes.
And let's give him 50 of fentanyl. He just seems to have a remarkable tolerance to the benzos as well as fentanyl. I mean, he's got some tremendous doses for having a little trouble. I mean, I think that he's going to...
See if that's a little too Versed.
Oh, you want to through and see where the wires are?
Here, right? 4, 5 total. Okay.
Okay, good. So I think he's calmed down a little bit here. Okay, so we're going to proceed with the stenting. And the stent
Wow, that
down.
went so
It
easy.
ain't a cipher.
Yes, absolutely.
20 atmospheres of
Okay.
We all breathe the sigh of relief.
Probably have to go down just a tad and then... All right, let's go up here.
We're at 12.
14. Okay. Let's go up again. Okay. So if you notice that, you know, that I'm using close to 100% dye in the inflation devices, and this is sort of a habit or whatever I picked up, I guess, at my old haunting ground in Sinai, and it just seems like, although not in this case, but in cases where there's heavily calcified vessels, you know, if you dilute the dye too much, it seems like you have a hard time deciding whether or not the lesion is inflated. Is anybody using 100% dye in certain situations, or?
Yeah, Rob, it's Jason. Yeah, I mean, in a case like this, I often do dilute it about half-half because I just want things to go up and down really fast.
Yeah, let's go.
But for normal PCI, I agree. But, you know, with hemodynamic like this, I think 50% dilution can just deflate the balloons so much faster. You can
I agree.
maintain the hemodynamics a little easier.
Yeah.
And with modern cath labs, you usually see very well,
Okay.
so there's no imaging issues even with 50% dye.
Yeah. And certainly here it looks like the dye's already been cut 50%, if you will. So,
Also tell you how it goes.
okay, so look, this is a 38 balloon. Looks like we're going to need at least a 32 or another 38. So we're going to need another insufflator.
All right. Moment, please. Yeah.
He's so stable now, you can just do a DK crush.
I think...
I'm not. I'm just being facetious.
Wouldn't you consider that, Ajay?
You know, the DK crush is, I think the data is good and you can recross easier, but, I still think that he's stabilizing, but he's still sick. That's why I asked if he's still on pressor. If anything, culotte you could do because you can do it relatively fast, but I think that in this situation,
Yeah, every time we inflate the balloon, you see he loses pulsatility.
So here, I'm going to get more of a selective shot here, but
Another issue is that you inflated the balloon in the left main, so basically you have a balloon injury there, even if we don't see it's microscopic balloon injury, and I would tend to cover everything, really go almost to the ostium here of the left main. We had a balloon inflation there, and patient is so stable, and see the pulse pressure now. So I think Ajay's suggestion, maybe it's not really a joke.
No, I mean the thing is that if the balloon that was inflated was like a 3.0, and the left main is so big that it sort of the degree of injury is going to be relatively low, I think.
So I think what we need to do is we need at least a 3.0, probably a 38 in the LAD, hopefully that protrude enough into the left main to be one arm of the SKS, and then I think in the left circ, I don't know, we could use a 2.5 or a 3.0. So I think
it's dominant. At least 3.0.
At least, yeah.
It's a 3.0. So the two 3.0s, that'll be a 6.0, and we're all told this calculation, right? The maximum that a parent vessel can accommodate is 2/3 of the sum, right? 2/3 of the sum of the daughter vessels. So I guess 2/3 of 6
is 4.
It's going to be a 4.0, and I think it'll be able to accommodate both a 2.3.0 stent. So I think we're going to need a 3.038 for the LAD, and probably I don't know, like a 3.024 to be on the safe side. It may be a long. So can we get those two stents, please?
3.038 and 3.024.
Yes.
Synergies.
Synergies.
Best pulse pressure we've had since we started.
So I think that bifurcation stents, there's been a lot of debate on whether to do a bifurcation stent, what kind of bifurcation stent strategy is the best, and just asking the panel, going through each members of the panel, is there a specific bifurcation stent that is better than the other, or is it just by a case-by-case basis what bifurcation strategy you would use?
38.
LAD.
Jason?
Yeah, so does your question of which bifurcation strategy for which patient, I think it's still an individualized decision. I think there's aspects about how much disease, what the ostium of the side branch looks like, and so on. Hemodynamic stability, obviously in this case. DK crush, mini crush. I think there's a couple of reasonable options, but I still think it's worth individualizing to some extent for each patient. And I'd add to that a selective strategy of just provisional bifurcation stenting is something else to consider.
So I think, and in terms of guide, I think this is one of the very few bifurcation stent strategies where a 7 French guide or bigger, at least a 7 French guide, is absolutely mandatory here. I think that a lot of the other stent strategies, the crush, mini crush, DK crush, I think can be done probably with a 6 French system, and I think this may be important when radial artery interventions are becoming more and more popular, where a 6 French 6 French access is still, I think, by and far the most common.
Yeah, agreed, Robert. I mean, if you went into this knowing what you were getting into, so to go in with a 7 French and plan for 2 stents simultaneous, you have to do it this way. There's no other way to do it.
Right.
The problem is when you're starting with the 6 French, and then you are more limited of what strategy to take. So starting is such a complex, left main bifurcation with the 7 French, probably it's the right thing to do because it keeps all the options open.
Right. So what is the role for a radial access then for complex interventions? I mean, is it not a good idea? It should never be considered, or do you do a 7 French via the radial artery? Or can you
I mean, with the availability of the 6-7 slender, or sorry, 7 and 6 slender, I mean, you can pretty much do most everything. Our CTO program, we've gone bi-radial. It is more of a struggle. There's no question about it. But the bleed rates, plummeted after it was done. So I don't think you have to be a zealot about things in general. Anybody who's so dogmatic in the cath lab about anything is probably going to be wrong. But if you weigh the risks and benefits, the bleeding risks and everything else like that, it's a pretty reasonable strategy. For these Impella cases, you can also use the radial, and certainly with the Glorin closure at the end, if there's any concerns, you can get a balloon to inflate. The only thing you have to worry about is you have to have the right length peripheral balloons, because from the right you lose about 10 centimeters. So if you don't have a long enough balloon, it's going to be hard to tamponade out the common femoral if there's a bleeding complication later, but you can inflate in the iliac. But you just have to be prepared for all of those scenarios.
So even with this dry cut at 50%, these are very big stent balloons, so we're having to do multiple negatives to get the stents down. Okay, so I think we're down.
So we are all waiting to see how it looks.
You can wait a little bit before injecting.
Injection, absolutely. I agree.
Actually, it's funny, the fellows don't realize, but contrast does not contain hemoglobin.
Yes, and you're reminded of it at midnight when a STEMI comes in, and the EF is 25% prox LAD, and your goal is to open it as soon as possible. You inject dye, and then, things get a little interesting. So, so the hemodynamics, I think, are improved, and I think it's safe to do an angiogram right now. I think it looks good here. I think there was a lot of saline there. So we're at about we're at 150 cc's of dye now. Go.
That's gorgeous.
I think it looks acceptable.
Are you going to do post-dilatation? Would anybody in the panel do post-dilatation?
Yeah.
Everybody knows with their heads.
All right.
And now you can IVUS at will.
Right, right. Should we, I think that what we could do is maybe do an IVUS. I mean, it's a double barrel now, so in a situation like this, you got a double barrel in the left main. Do we need to IVUS both barrels? Do we IVUS the LAD barrel, circ barrel? Is there a correct answer to this question?
Well, I mean, I think just because you have so much length of stent in the LAD in that prox segment, you arguably could be 3.5. I think you want to see that, and there's no downside to doing both, just to be sure that everything's fine.
So we're going to IVUS down the LAD barrel. And what we're using here is we're using a Boston Scientific IVUS. We're using their 5 French version.
Yeah, I mean, you can see from the rim of calcium in the Prox LED that at one point in life it was a lot bigger than it is now, so it's reasonable to look at it.
The other way?
Yeah, the LED looks smaller than the circ here. So. But let's see the IVUS.
Propose a circ wire.
So you're on the LED wire?
Yes.
Yeah.
Now, the only thing with these types of cases is because you have that neocarina in the ostium, if there's any resistance to the IVUS catheter, especially with Synergy, you got to be really, really careful because it's so open-celled that the deforming it in that area would not be a good thing. But it passed very nicely.
Okay. So I extended the IVUS beyond into a disease-free segment so we can. Okay, pull back.
We're still distal to the stent.
Yes. We're coming up on this.
Now we see the stents coming in. It's nice transition. This area there between like 12 and 4 o'clock that I'm not sure there's a fuller position. It's maybe important to look at that again.
Right. I agree. It seems like it can be post-dilated a bit.
Definitely has to.
Use a 3.0, use a 3.5 balloon, non-compliant.
It's a 3 of vessel, so this area. So the 3 of balloon will work. Even here.
I mean, the prep work you did, though, shows because, there was a lot of calcium there, but you have, the expansion is good. It can be bigger, but at least you don't know, you don't have any areas of focal under expansion.
Where are we now on the angiogram?
So we haven't gotten to the double carina yet, or the double lumen.
Okay,
We're
proximal LED there.
Yeah, we're approaching it.
Yeah, here it's relatively narrow. You can enjoy significant post-dilatation.
Well, now it should be coming soon.
So we should be approaching the double lumen soon. I think this is it.
There you go.
Yeah.
All right. So based on this, it seems like we need to go down with a 3.5 20 balloon, inflated to sort of moderate high pressures distally, and then as we bring it back proximally, go up to 20 millimeters of mercury or more. Now the question here is, should we save time and have a balloon down the left circumflex as well, so that as we pull back, we can do a kissing balloon post dilation in the carina.
I think so. I mean, I think you could safely assume that the circ needs to be post-dilated as well.
Right. Okay, so can we get another 3.5 for the circ or a 3.0 for the circ?
3.5.
Yeah, let's get another 3.5. All right.
You can increase the pressure as you walk up the LED, as you go from distal to proximal.
Right.
How they do. You see the whole. What's the wire? Where's the other 3.5?
It's coming.
Go up.
12?
14.
14.
16.
16.
Down. So let's dilute the.
Yeah, we forgot that.
Okay. Okay. Go up. Go up to 18.
18.
Can we get another 3.520? Oh, it's.
Yes, sir.
And let's cut the die a little more. Double the die.
How is the hemodynamics now?
The hemodynamics now,
Better.
actually,
Cut the
much
die.
better.
Nice.
Did I hear you ask, though, to dilute the contrast on the circ one?
Yes.
Yeah,
even
no,
more.
we were laughing. That's prudent. That's very prudent. The problem with these flat lines is you just never know when it's not going to come back.
Yes. Yeah. That's a very good point.
Okay, 16,
18,
18,
20.
20.
Okay. Okay.
Jesus.
Here, go up here. Okay, 16.
20.
All right. Now we're going to need that other balloon soon. Okay. It's diluted. It's diluted.
Yeah.
Okay, good.
So this is how I do.
Yeah.
This is circ.
For a second, I don't know if it want to move. There we go.
Go up.
8, 10, 12, 14,
16. Good.
16.
Down. Okay,
LED.
go up to 8.
8.
Now I'm going to go up high. Go up to 8. Go up 16, 18. Down.
Down to 8.
Let's go up together now to 8 atmospheres.
8.
That's impressive.
Okay. So what I do here, I mean, if you don't have it, so this is the circ. What I try to do is get at least one balloon out and completely disengage the guide. I mean, especially I think that if you find yourself in this sort of a situation without any kind of impeller support. And I heard you, Ajay, I mean, during those periods of absolute non-pulsatility, you're just holding your breath, hoping it's going to return. Okay.
So then it always comes up in these cases, you know, what do you do with the support device? Do you leave it in at the end of the procedure? Do you take it out? You know, I know, you know, Samin always talks about typically trying to remove it and put a balloon pump in the end. But this type of case with what occurred before and everything else, I would tend to leave it in.
Right.
Yeah, I think leaving it in at least overnight is very, very reasonable in this patient. And you know, occasionally we take them out early and you get burned and you're back in at midnight putting it back in again. So I think leaving it in overnight, there's very little downside to 12 extra hours or something with the impeller.
Yeah. If there's no leg going issues in this case, I would leave it until tomorrow morning.
Right. I agree completely with the panel.
It helps you wean the pressors as well more aggressively.
Okay, so the pressure's fine, good pulsatility. I think we can do an angiogram here.
Relax now. We'll give him a little bolus as we do.
Yeah, let's give him a little more.
Want it or put it over here?
Give him like 2.
Just doing the same.
That's great.
It looks beautiful.
So I'm gonna just do just a cranial shot, and I think.
I'm going to do low mac.
Robert, the only thing that we didn't see clear is the distal edge of the circ stent.
Okay, so I'll do
see
a.
it.
Yeah.
We'll do a caudal.
Yeah, you can see it there. That's great.
Do you think
Okay.
this is an RAO caudal, or you guys are happy with this?
Save the die, I think.
Yeah, we're at 189 cc's a die. You know, he had normal creatinine clearance, despite his reduced cardiovascular function. So, on that note, we were lucky. So, well, thank you. I think that this was a challenging case, but you know, with the right approach, I think we were able to get the patient out of a near-death situation, and I think the comments made by the panel were certainly helpful in terms of deciding to do SKS, which is a very simple, I think, bifurcation stent strategy, but without that much, without any robust patency data. But I think in a situation like this, you have to do what you can and get out. So
We got to support. We got to.
so great case. So the plan today is to leave the impeller in overnight and see how he does, and then if he's doing better, we'll take the impeller out. Try to extubate him in the morning. Well, thanks.
We're going to thank
Great
our
job.
supporting staff. Has been amazing throughout
Very nice
the
work.
beginning of this case up to now.
Yes.
Robert, Jose, rest of the Cath Lab team, thank you very much. Excellent two cases, also the case that Jose did in the morning, and this case was a great bailout and really demonstrating how you can get out of trouble and help the patients. And thank also the panel and the rest of the audience for a really very interesting day. I think we learned a lot. I definitely learned a lot, both in the morning for the peripheral interventional cardiology and afternoon for the coronary one. So thank you and enjoy the rest of the evening.
Yes. Thank you.